first session, it is my pleasure to introduce Professor Varocha Mahachai. She is a distinguished clinician and academic leader, renowned for advancing Helicobacter pylori management and gastric cancer prevention across the Asia Pacific. She is currently an academic advisor Excellence Center Digestive Disease at Thammasat University. For another moderator, Professor Francis Chan, he is a world-renowned clinician scientist in gastroenterology, currently serving as the Cho Ming Lee Professor of Medicine and Therapeutic and the Director of the Center Gut Microbiota Research at the Chinese University of Hong Kong. Please warmly welcome Professor Varocha and Professor Francis Chan on the stage.
Good morning. So we started the first session for today, Mastering Functional GI Disorder, and I would like to introduce my colleague, Professor Francis Chan. Everyone knows him. He doesn't need further introduction. He's from University of Hong Kong. So we have two speakers this morning, and Dr. Chan will introduce the first one.
Right. Thank you, Professor Mahachai. This morning, we have got two speakers focusing on functional GI problems. I would like to introduce our first speaker, who is Dr. Lawenko from the Philippines. Dr. Lawenko is currently a consultant and also an assistant professor of the College of Medicine, De La Salle University Health Sciences Institute. She received her GI Motility Fellowship in Malaysia and has been working in different places in different hospitals in the Philippines and other parts of Southeast Asia. So I believe she will be one of the best persons to share this very important aspect. Today, she will talk about the future forward management of functional dyspepsia. Dr. Lawenko, please.
Hello, good morning. Thank you for the kind introduction and thank you to the organizers, Professor Issariyakulkarn, for the kind invite to come to your wonderful country and this conference. So to everyone, thank you for joining this morning's session. So I'll be presenting Future Forward Management of Functional Dyspepsia. And in this talk, I will discuss evidence-based management, emerging therapies, and look at research gaps and future directions for this condition. Functional dyspepsia, we know, is clinically diagnosed by the Rome 4 criteria. It's a chronic disorder with postprandial fullness, early satiety, epigastric pain, with subtypes, namely postprandial distress and epigastric pain syndrome. The global prevalence is 7% with regional variation, and in our region, Southeast Asia and some parts of East Asia, the prevalence range from 5 to 18%, with a pooled prevalence in the entire continent at 8%. The PDS subtype is more common, it's more frequent in women, and appear to decrease as patients get older. Now, functional dyspepsia, it's multifactorial or otherwise complicated. It has a lot of risk factors like H. pylori infection, post-infectious gastroenteritis, smoking, NSAID use, psychologic comorbidities, and more recently, genetic predisposition, a history of childhood abuse, dietary triggers, and dysbiosis have been documented. And it's also driven by many newly recognized mechanisms. And we know that impaired gastric accommodation, delayed emptying, visceral hypersensitivity, duodenal eosinophilia are involved. But there are now more novel contributors such as mitochondrial dysfunction, microbiome imbalance, oxidative stress, gut-brain connectome remodeling, and more emerging frontiers now include genetic and epigenetic control, the so-called metabolo-immunoneural axis. So there are many, many active areas of investigation, and all this new information is really paving the way towards precise and hopefully mechanism-based approach to therapy. And in addition, recent data suggests that functional dyspepsia and gastroparesis exist on a continuum, in a spectrum, and not separate diseases. And this diagram shows that there is significant symptom overlap between the two. and that the shared mechanisms are as follows, but there are some FD predominant mechanisms, like there are more duodenal issues in functional dyspepsia, while in gastroparesis, a predominant feature is more of gastric motor and gastric inflammation. Now, overall, our improved understanding of functional dyspepsia with its interconnected mechanisms really just tells us that in this broader model, functional dyspepsia is really not just simply a motility disorder, and that all of these are now targets for more individualized care. But despite advances in mechanisms, there is no FDA-approved drug for FD at the moment, and all guidelines really promote a stepwise approach. You want to talk to the patient, educate them, make a positive clinical diagnosis, avoid unnecessary testing, and advise proper lifestyle changes. You want to explore dietary modification, and then give them or treat pharmacotherapy, their main symptom, and then consider behavioral therapy like CBT for severe cases, and then monitor progress with a robust follow-up plan. And over the past decade, multiple societies across the world, including North America, Europe, and Asia, have released updated dyspepsia guidelines. While there are some differences, generally the stepwise approach is consistent to all. We begin with diet. We know it's central to symptoms. In over 70% of patients, they have their symptoms that are triggered within 45 minutes, 15 to 45 minutes of eating, with fat or lipid as the strongest dietary triggered, followed by FODMAPs. Alcohol, coffee are also implicated but have limited data. And then these would then interact with your abnormal GI mechanisms, which lead to your symptoms. Dietary guidelines differ regionally because of differing populations. The Mediterranean diet show evidence for lower dyspepsia risk and is recommended in some regions, while low-fat diet is universally recommended because of its significant role in relieving postprandial pain. Low FODMAP diet, we know, reduces symptoms in IBS and has shown early promise in functional dyspepsia in a recent meta-analysis, especially the PDS subtype or those with predominant bloating. However, this study was limited by heterogeneity. So this one is recommended in our Asia-Pacific, Mexican, and Belgian consensus. Now, careful carbohydrate reintroduction post-FODMAP has also been shown to be beneficial in a recent prospective cohort, but this one has only been mentioned in the Asia-Pacific 2023 guidelines. Some patients report improvement with a gluten-free diet, but meta-analysis showed that it was not significant, thus not routinely recommended. Other dietary approach, the DASH diet for hypertension, which is high protein, high unsaturated fat, it appears to be, however, poorly tolerated in functional dyspepsia. A newer diet called the Eat Lancet diet, which is a plant-based diet with less processed foods, is being studied in a recent cohort and was associated with lower FD prevalence and maybe something we need to look at in the future. So here, summarized are the key dietary recommendations in Asia. We, again, focus on fat restriction and identification of triggers. While in North America, the Mexican guidelines is somewhat the same with us, but the American Canadian guidelines did not mention any specific diet other than a healthy diet. In Europe, the British and Italians are the ones who advocate Mediterranean diet, but the European consensus did not really give a formal recommendation. So moving on to therapeutic strategies, we have pharmacologic. Acid suppression, PPIs remain the first strong line for FD, providing 9% benefit over placebo. H2RAs are alternatives but have smaller, less durable effects. Antacids, sucralfate, bismuthalone, and ribamipide show no clear efficacy or thus are not recommended. Vonoprazan, PCAB, is promising with over 70% improvement in refractory dyspepsia, but given only a conditional recommendation in Japan guidelines, given that the guidelines were created in 2021, which is likely to change as more and more data is evident. H. pylori is recommended as first line across all guidelines as meta-analysis confirmed symptom improvement. And regimen should be tailored to local resistance as what we have been discussing in the Southeast Asian consensus meetings. Now, vonoprazan-based therapy yields very high eradication rate, as proven by this meta-analysis, compared to PPI-based regimen, is given a conditional recommendation as alternative to H. pylori-based eradication therapy in both Japan and in our region. Rifaximin is beneficial due to its effects in dysbiosis and proven to be better than placebo in this RCT because of its improvement in bloating, but is still considered investigational and not recommended in some guidelines. Only our region, Asia Pacific, considers it a good recommendation. The next group are prokinetic drugs that work by targeting motility. We have your domperidone itopride, gives about 14% benefit over placebo, followed by your 5-HT4 agonist, mosapride, with about the same benefit, with metoclopramide having the highest efficacy, but we know is limited by safety concerns. And although modest, these drugs are generally accepted in our region, but limited in Western use. Acotamide is found to be effective in PDS subtype and is endorsed in both Japan and Asia Pacific guidelines, but is not limited by not being widely available in many regions. Now, other drugs like levosulpiride and has efficacy over placebo, as well as motilitone, a herbal-based prokinetic supported by Asian RCTs, making it also a good option. But together, these are still either investigational or given conditional recommendation. Now, prucalopride, velusochag are in their early phase trials, but aren't widely available, so considered investigational. Likewise, acotamide plus nizatidine combination has shown preliminary promise, but is still investigational. So in general, prokinetic choice is really best guided by availability. Neuromodulators play a second-line or add-on role, especially in refractory cases. We know TCAs, amitriptyline, imipramine, nortriptyline are well validated for symptom improvement with reasonable safety, thus are universally recommended as second-line. Now, mirtazapine may help with early satiety and weight loss being your predominant symptom. Anxiolytics, like the following, are used as adjunct and improve gastric accommodation, but they have limited evidence. Now, non-invasive neuromodulation is the emerging investigational strategy in FD that improves gastric accommodation and has future potential. Anti-inflammatory drugs, logical choice to treat inflammation, but montelukast and mopolizumab has been studied more in those with eosinophilic GI disease with FD-like symptoms, has some potential, but there's limited data at the moment. Both are experimental and further RCTs are needed. Next are your behavioral and psychologic therapies, which refer to interventions designed to change a patient's cognition, perception, or behavior. We have cognitive behavioral therapy, or CBT. It has the strongest evidence with symptom improvement globally and is recommended. Psychotherapy targets emotional conflict and only benefits those with underlying history of trauma. Relaxation therapy, also very good, well tolerated, and often combined with other therapies and is recommended. And overall, these therapies are safe and recommended as adjuncts, but I think the issue is that it may not be available, these kinds of services, in all regions. Hypnotherapy as well, it's effective, over almost 30% absolute benefit and improvement in symptom scores with no major adverse effects. Newer behavioral therapies are called mindfulness-based stress reduction. It's a promising strategy for reducing stress and hypervigilance and shown to be showing absolute benefit in symptom scores up to 20%. And then the last behavioral treatment is biofeedback-assisted relaxation, which did show benefit in one's RCT. And again, these two need further validation studies. Now, microbiome-targeted strategies, it's a rapidly evolving strategy in functional dyspepsia and so many other GI conditions as we've learned yesterday. So multi-strain probiotics, they're widely available, and these specific strains have been studied in functional dyspepsia and did show significant improvement, however, did not show significant improvement over placebo in a 2020 analysis, but one 2025 recent RCT showed benefit. So this is not to rule out multi-strain probiotics, and we are going to need to wait for more data. And it's similar to the specific strains. Now, fecal microbiota transplantation as well as dietary microbes are still investigational but could really transform future practice. And these interventions, the last two, are not guideline endorsed, but we will have to wait for, I believe, Dr. Ratakorn's data on FMT in functional dyspepsia they mentioned yesterday. So for integrative and traditional therapies, refers to your herbal and traditional medications that target motility, inflammation, and the gut-brain axis. And these remedies include your iberogast, peppermint, caraway oil, which provide up to 30% benefit over placebo, and both are recommended in Asia, Mexico, and even Italy. And it's considered complementary to your standard care. Riconchito is shown to be likewise beneficial, available in Japan. And the acupuncture works by stimulating specific points in the body to enhance motility, reduce visceral hypersensitivity, with up to 40% benefit in a meta-analysis with mild side effects, and is recommended in some regions. Others are recognized in select regions like Korea and China, and most of the evidence come from small randomized studies, and these are, however, investigational and best considered as adjuncts for interested patients, and the same goes for ginger, artichoke, and the combination. The last is digital health interventions. This includes technology-based tools or programs designed to support diagnosis management, education, or even behavioral change in FD. And these interventions include a mobile CBT app. It's a gut-directed CBT program that delivers CBT via mobile app, and early studies in New Zealand and China showed promise. Symptom trackers like My GI Health and GI Tribe allows patients to record symptoms, medications, or dietary triggers, and is becoming something we can recommend to our patients in a practical sense. Virtual visits or telemedicines with gastroenterologists, psychologists, dietitians, which are done remotely. It still needs more evidence, but it's really, really promising, especially for regions that do not have access to specialists like GI psychologists. Next are digital education tools that provide patient-directed e-learning to aim for better informed decisions and sustainable lifestyle change. And then wearable devices like gastric sensors are also have some pilot studies and may hold potential for future care. Mindfulness app and even virtual reality are emerging digital health approaches in functional dyspepsia. The first one, it's a form of relaxation delivered via an app. And a VR is when you immerse your patients in a digital environment to distract them from pain and reduce their hypervigilance and their symptoms as well. So these are not recommended, but research is promising. And these are, for the younger GIs, are numerous mobile apps that you can, that target functional dyspepsia, from symptom diaries, food trackers, digital health, telehealth programs. So I think these are something you can now offer to your patients, especially those without access to care. Now, online education, it's a powerful tool. Examples are your IFF, GD, and Mayo Clinic. They give us free, expert-reviewed patient education library that may help bridge knowledge gaps in some region. For wearables, just quickly, gastric allometry, it's developed in New Zealand that allows gastric mapping, and it's in its research stages that may have some benefit in the future in functional dyspepsia, as well as this AbStats. It's a FDA-approved device or wearable from the US. It's a patch that you put in the in the abdomen to detect motility changes in real time. It's a so-called gut speedometer. And then again, I mentioned virtual reality. So to summarize, this is the big picture in FD management, options across international guidelines. No matter where you practice, really strong agreement for three things: PPI therapy, H. pylori, and use of prokinetics, followed by neuromodulators. While behavioral therapy is also widely recommended, integrative more in our region, not in the West. And then emerging therapies, microbiome, are still in the investigational phase, but has a lot of potential. Research priorities, we want to find out universal biomarker. We want to have more practical guidelines for dietary advice. We want more data on other neuromodulators as well as in the traditional therapies. Just in passing, this is the emerging candidate for biomarker in functional dyspepsia, the use and the role of neuroimaging, as well as biomarkers for gut neuropeptide. So Future directions. Moving forward, we will wait for the updated Rome 2026 guidelines. And then we are now waiting for the role of emerging biomarkers and an eventual shift to targeted or personalized gut-brain therapy. To end functional dyspepsia, it's complex, it's evolving. There are many now treatment options, but we need better evidence. From microbial therapies to digital health, we are really in an era of expanding option and learning together with our patient for future solutions. I'd like to invite all of you, especially the younger GI community in the stage and in the front row. If you would like to join the Rome Foundation Partners Program, it's an online community. Membership is free. And this platform and community really aims to offer interactive content in the field of disorders of gut-brain interaction like functional dyspepsia. And from our region, yours truly, Dr. Chai from Taiwan and Professor Ruben Wong from Singapore are part of the community. And we hope you can join today via this QR code. Thank you for your attention.
Thank you. Thank you, Dr. Lawenko, for giving us such a comprehensive and concise overview on the management of functional dyspepsia. We will leave the Q&A till the second speaker has finished her presentation. I'd like to ask Professor Mahachai to introduce us the second speaker.
I would like to invite the next speaker, Dr. Navapan Issariyakulkarn. She's a faculty member of Thammasat University GI unit. She has certificate in neurogastroenterology and motility. That's her area of expertise. And she completed her master's degree at the Bath and London School of Medicine and Dentistry, Queen Mary University, London. And she will give us the talk today on the very difficult problem in GI, on the management of, or to try to find solution of chronic constipation. As you know, it's a very difficult problem in the GI practice. So please, Dr. Navapan.
Good morning, Mr. Chairman, ladies and gentlemen. Thank you for ASEAN Gastro 2025 for inviting me to be today. My presentation today is focused on chronic constipation, the tailored solution for chronic constipation, the last trace in treatment and management. This is my disclosure. Today, I will start with pathophysiologic-based subtype and diagnostic tool for chronic constipation, and now we will talk about the novel treatment. The prevalence of chronic constipation in Asian studies like South Korea, China, and Indonesia is quite high, around 15 to 23% in women and about 11% in men. This is higher than what we see in many Western countries. The burden is significant, but it remains underdiagnosed. The main of chronic constipation diagnosis remains the Rome 4 criteria. To meet the criteria, a patient must experience 2 or more of the lead symptoms, which are grouped into quantitative signs and subjective symptoms, which are the 3 chronicity requirements. These criteria must be fulfilled for the last 3 months, with symptom onset at least 6 months before the diagnosis. And how can we manage the chronic constipation? Firstly, we should classify into primary or secondary constipation. For primary constipation, we classify into IBS-C, which the patients must have abdominal pain related to defecation. Functional constipation, which are divided into normal transit constipation or NTC, symptoms are present, but transit time is normal. Slow transit constipation, a truly motility disorder, where stool movement through the colon is delayed, and functional defecation or pelvic floor dyssynergia are problems with the mechanic of stool expulsion, offense and outlet disorder. For the secondary cause, which are drug-induced, I will focus on opioid-induced constipation. Systemic other constipation can be caused from systemic association or organic cause. To effectively differentiate this subtype of functional constipation, We must rely on objective diagnosis too. For the disease, normal transit constipation, for chronic transportation, the chronic transit study is key. It can be done by using the opaque marker, wireless capsule, or scintigraphy. But the simplest way is to do radio-opaque marker study, where greater than 20% marker retention on day 5 indicate delayed transit. Next, when a motility disorder is suspect, we must exclude structural pelvic floor disorder like rectal rectal interception, or rectal prolapse. We differentiate them from the true functional defecation disorder. For this, defecography or MR defecography too essential to visualize any abnormal anatomy during defecation. Dyssynergic defecation is about coordinating problem, the inability to relax the pelvic floor muscle to allow the stool expulsion. We use anal-rectal manometry for the diagnosis. ARM is essential for measuring sphincter tone and the rectal sensation. However, if we do not have ARM, the simple way to assess this group is digit rectal exam. During PR and tell the patient to push, you can feel the abnormal anatomy and the abnormal sphincter contraction with high positive predictive value. Or using the screening tool balloon expulsion test or BET with abnormal time is less than 60 seconds can help to diagnose the outlet disorder. However, BET does not distinguish between functional and mechanical cause of this defecation disorder. Moving to the treatment, the foundation remain conventional care. Non-pharmacological treatment are the first line of defense, including increased soluble dietary fiber, increase fluid intake, do more exercise, or establishing a regular toilet routine. Some studies show drinking coffee, adjust toilet position, and do abdominal massage can help in mild constipation. In Thai guideline, probiotic remain controversy because different strain and different patient response. We do not recommend the patient to do transanal irrigation by themselves. When pharmacological is needed, we start with the traditional agent, bowel-forming laxative, osmotic laxative such as PEG or lactulose or MOM, and as need stimulant. Currently, there have been significant development in novel medications specifically for patients who do not respond to conventional laxative. I will compile some of these key advancements and we will now review them. First, the secretagogue, including linaclotide and picanalide, they work by activated glutamate cyclase C with increased fluid secretion into the gut lumen. Let's differentiate between two medications based on two key factors, the eligible age of use and the medication of administration. Linaclotide can be used safely in children aged 6 years old or older, offering an option to our younger patients. In contrast, picanalide is approved only adult use. Regarding administration, linaclotide must be taken half an hour before meal. However, picanalide can be taken at any time, providing more flexibility for the patient. Second, we have pucallopide, a high selective 5-HT4 agonist that effectively stimulates colonic propulsive motility. For dosing, remember to halve the dose in patients over than 65 years old or children below 13. Use this medication extremely caution in child class C liver disease. Common side effects including headache and abdominal pain, usually more prominent in the first few doses, then improving. I always discuss these potential side effects upfront my patient to manage expectation and ensure adherence. Third, the IBAC inhibitor, ilobisibak, which inhibit bile acid reabsorption, leading to increased bile acid in the colon to stimulate secretion and motility. Due to the minimal systemic absorption, this medication has few side effects. However, My experience shows some patients get severe diarrhea starting with 2 tablets. I advise them to monitor for severe diarrhea and self-dilute the dose if it occurs. And finally, for opioid-induced constipation, the target therapy is Palmula, neodymium, which acts peripherally to block constipating effect of the opioid in the gut. Unfortunately, this medicine is unavailable in Thailand. The functional dyspepsia is now recognized as one of disorder of gut-brain interaction. And we now understand that gut dysbiosis, specifically a reduction in short-chain fatty acids producing bacteria such as Bifidobacterium lactobacillus, impact chronic motility. This dysbiosis can lead to an impaired intestinal mucosa barrier and alter colonic function through various bacterial metabolites. Therefore, we no longer just talk about gut-brain axis, but have fully incorporated with microbiota, referring to it as the microbiota gut-brain axis. This highlights the critical three-way communication influence gut health and motility. So how we modulate this? Microbiota modulation can do with using prebiotic, probiotic, postbiotic, and fecal microbiota transplantation or FMT. Now let's look at an interesting study on prebiotic and constipation. A Thai study investigated the use of prebiotic resistant starch type 3. This is type of retrograde starch from when starch food like potato and rice are cooked and then cooled. The study conducted over 12 weeks showed the daily intake of this specific resistant starch significantly increased the level of beneficial bacteria in the gut. And crucially, it also leads to a marked increase to frequency, demonstrating as its potential as a beneficial prebiotic for constipation management. Moving to another well-known prebiotic, fructooligosaccharides. The recent meta-analysis showed this prebiotic significantly increased bowel movement frequency and subsequent stool and reduce the effort during defecation with mild bloating. Another study of symbiotic from network meta-analysis showed symbiotic increased the number of weekly stool movement. Moving to probiotic on constipation. The recent meta-analysis showed they can help improve constipation symptoms. However, it's important to note that almost all these studies show publication bias. This means we need to interpret the finding with some caution. However, another meta-analysis specifically looking at probiotic in the elderly patient with constipation showed that probiotic increased bowel movement frequency and help with symptoms associated with constipation, but it did not improve evacuation defecation difficulty or need to manual maneuver. The good news is side effects were very low. A key point to remain here is that study including in this meta-analysis was generally of low quality. Now turning to postbiotic and their role in constipation. We currently have two notable studies. One example involves a product called Probioeco, which is essentially a ferment derived from beneficial bacteria. This study found Probioeco significantly improved constipation symptoms, reduced staining, and also increased the population of beneficial bacteria. And a second study of postbiotic using heat-treated fermented milk found similar positive results to the first study. This further supports the potential of postbiotic for improving constipation symptoms and gut health. Finally, let's assess fecal microbiota transplant for constipation. A recent systematic review and meta-analysis published this year found that FMT can help improve stool consistency, quality of life, and symptom severity. Importantly, it also shows a significant post-FMT effect on microbiota alteration, suggesting the mechanic change in the gut environment. So we have explored the evidence and study on microbiota. Now turn on our attention to the practical recommend and guideline for microbiota. Probiotic is recommended to use as an alternative or complementary therapy when conventional options are insufficient from Japan guideline. The recent guideline that was published this October, the British Dietitian Association Dietary Guideline, give more detail for using probiotic. They recommend the specific strain Bifidobacterium lactis and Lactobacillus coactans, and advise to use probiotic at least 4 weeks to assess the benefit. This guideline shows symbiotic does not demonstrate consistency benefits for stool frequency, consistency, or comorbid symptoms. This guideline also recommends use prebiotic like inulin and physium as the with strong recommendation. Now moving to the new technology. For this synergic defecation, the main treatment is anorectal biofeedback therapy. This therapy teaches patients to effectively coordinate their muscle for defecation, aiming for better straining and relaxation. We see a high success rate, around 60% of patients. However, always conduct anorectal function test first. They'll help us pinpoint the specific problem like weak pushing force or paradoxical sphincter contraction, ensuring the biofeedback training is precise tailored for the maximal benefit. And let's look at the new and exciting new technology for constipation, the vibrating capsule from Israel company. A post-marketing study on the vibrating capsule showed very promising results. After 3 and 6 months of use, patients experienced more than 1 additional spontaneous bowel movement per week. Furthermore, their Bristol-Stool scale scores changed significantly. Patients also report reduced time spent in the toilet, and importantly, the capsule was found to have a high safety profile. This represents a novel, non-pharmacological option for chronic constipation. Next, we now turn on a technology that is not entirely new, but it has seen growing interest in the application for constipation, the neuromodulation. Specifically, we are now looking at tibial nerve stimulation and sacral nerve stimulation. A systemic review and meta-analysis on tibial nerve stimulation reveals some interesting findings. The transcutaneous tibial nerve stimulation appears to be more effective than percutaneous tibial nerve stimulation. Study on transcutaneous tibial nerve stimulation, typically 2 to 6 weeks, shows significant movement in constipation symptoms and reduced defecation time, while the percutaneous primarily improves early quality of life. However, the research also highlights significant heterogeneity across studies. This includes difference in stimulation methods, unilateral or bilateral, stimulation frequency in hertz, and importantly, different constipation subtypes, including in the patient selection. This variability underscores the need for more standard research to fully harness the potential of neuromodulation for constipation. In contrast, many studies show the effect of sacral nerve stimulation, but the double-blind RCT crossover showed no significant effect. And the one more technology is not the quite new, is the traditional Chinese medicine, the acupuncture, is now support to treat constipation by increased spontaneous bowel movement in specific constipation condition, but by low to moderate quality evidence. To summarize my talk, effective treatment starts with identifying the phenotype of chronic constipation, whether it's the normal transit chronic time, slow transit time, or the defecation or this other. This is the opioid-induced constipation. This tailored management is truly the key to achieve better outcome for our patient. Always begin with the lifestyle modification and the conventional laxative as our first-line approach. However, if the response is inadequate, then it's time to add on the novel medicine and more specific treatment based on that identified phenotype. That is my takeaway message. Chronic constipation is heterogeneous. Diagnosis should be phenotype-based. The tailored management leads to better outcome, and microbiota modulation is an early, safe, and promising therapy strategy. It's not just a supplement. Combining diagnosis, prescription, and modern therapeutic can improve patient quality of life. Thank you for your attention.
Thank you, Dr. Navapan, for your excellent lecture. So now we welcome any question from the floor, maybe a couple of questions.
So thank you so much for both of speakers. That's fascinating talks. So as the Professor Nawan showed, I believe that the microbiota disperses maybe play important roles in the lower GI diseases such as IBS and chronic constipation. Rona, for the upper GI disease such as a functional dyspepsia, right now they have any emerging evidence to show that they may play a role for the pathogenesis, even for the treatment in the patients with the functional dyspepsia about the microbiota disperses.
Are we so in terms of emerging evidence for? Did I hear it right? Fecal.
Yeah. No, I mean the microbiota disperses. They may be have any roles in the functional dyspepsia for the pathogenesis, even for the treatment.
Yes, so it's really the same as most of the other functional GI diseases. It is now shown to be an emergent frontier in terms of the concepts and the mechanisms involved in functional dyspepsia. So it's really becoming the thing that is being studied, with all the neuropeptides, the microbiome, the gut-brain remodeling, all of these microbial metabolites. Correct, I agree that completely. It's the trend now is, as I said earlier, it's no longer just a motility issue. It's really looking at dysbiosis, the effect of dietary triggers, and the dysbiosis and the axis that we all learned yesterday, the immunoneural metabolic axis is all related in terms of functional dyspepsia, which is almost consistent with all the other functional GI diseases and like IBS. No? So it's really nice that this is going to be really something very important. The microbiome targeted therapies for functional dyspepsia, I think, is going to be the thing that we're going to be looking at in the next few years.
Thanks.
Dr. Issariyakulkarn.
Yeah, for Rona, so one of your slides mentioned about the capsaicin is one of the treatment for functional dyspepsia for one RCT. So what is the reason of capsaicin work for our functional dyspepsia? And also for you about the using the eloxybisat, GOFIS, how long in your experience to give this medicine for your patient with the chronic constipation? Thank you.
So, yeah, it's interesting. No? So, capsaicin, I think it's more of desensitization, so we're thinking that dyspepsia, it's really a multifactorial thing. So, I think the theory there is that it's going to sort of basically cut down or stop the dysfunction. It's desensitization. Really, it has something to do with hypersensitivity. But I think, as I mentioned, it's really investigational. But I really just opted to put it out there because just to say that there's really many things we can look at because we come from many regions, very different triggers. So I think it's important that we do not really discount them, even though logically we would expect that it will cause your more symptoms. I think it might be not opposite or negative in terms of GERD. No? So I think if you're dealing with a pure functional dyspepsia patients, which is not always the case, it might not be a good thing or option or adjunct to think about because we know it's not going to be beneficial in someone with FD GERD overlap. So I think its role is, I think, going to be just reserved as an adjunct in those patients who are interested.
If possible, I'd like to ask our second speaker a follow-up question with regard to the use of probiotics in constipation among the elderly. I remember you showed one slide about a systematic review and meta-analysis of the use of probiotics for the elderly with constipation. In your practice, in your opinion, how useful are probiotics for constipation?
For the first question, the duration of the group phase, in my experience, I will tell the patient if you respond of the group phase in the same day, you can use it as need. But in my experience, the chronic constipation is more complex. If the patient cannot change the lifestyle and they cannot change something like this, I tell him use it as long as possible. For the second question, the probiotic in constipation, in my opinion, because different strains are selling the marketing, I tell the patient try some strain of probiotic at least for 1 month. If it's not work, you can stop it because there are different strains and different response in each patient.
Thank you.
One short question for Lawenko. Any association with SIBO, with dyspepsia? We often have patients come and say, wondering they have SIBO.
Yes, so I think I agree completely that because of the symptom of bloating, so it's not going to be simplistically one mechanism involved, functional dyspepsia, and that's why I think rifaximin is really something that is being used and is found to be beneficial because of the connection with functional dyspepsia and SIBO. The dysbiosis in general is, I think, what's being targeted in rifaximin. So rifaximin is something in our practice in the Philippines that we really use and is real world, meaning our experience really is effective for the postprandial symptoms in those with functional dyspepsia, especially in those who have overlapping functional bloating and IBS symptoms as well. Thank you.
Thank you very much. So we close the session now. Thank you, Francis, for joining us and both speakers. So please give them an applause.
Thank you.